So my topic is immunomodulatory drugs, advances in disease pathogenesis. This is my slide to remind myself that this is that every star may be a galaxy, and every galaxy may be a target that we can exploit for treating human disease. We're going to talk about the nature of immunomodulatory drugs from a very basic element. We're going to talk about the changing landscape of them. We're going to talk about the galaxies of targets that are out there, and I'm going to focus on just C5 and anti-IL-5. And we're going to talk about a warm-up for the discussion of kinases. So what are the types of immunomodulatory drugs that are out there? There are the protein-based therapeutics that you all are aware of. These are antibodies or soluble receptors. They're parenteral. They are all competitive inhibitors, and we'll talk about what that represents. The small molecules are the other types of drugs. They're typically a molecular weight under 1,000 Daltons in comparison to an antibody, which is about 180,000 Daltons. They're oral, and they come in both competitive and non-competitive frameworks. Now, I love to show this slide because I know everybody's going to be groaning. The point of this slide is just to remind you about competitive versus non-competitive inhibitors. If you have an enzyme E and you have an inhibitor I, that association to form the complex, that initial non-covalent complex that results in the inhibition of the enzyme, is a synthesis of the on and off rates shown on the left-hand side. However, if your inhibitor is a covalent binder, meaning it forms a covalent bond to the enzyme, it forms a covalent complex on the far right, and it's basically essentially all on and never off. I want to remind you that this is important when you think about your antibodies that you use in the clinic. Here's your KD for golimumab, infliximab, etanercept, and adalimumab, and this is for soluble TNF. And the KD, as you can see, is 18, 44, 11. Etanercept comes out as the champion, and adalimumab is 127, a little bit lower. That's for soluble TNF. Remarkably, and we know this, and we've known this, but it's kind of drifted into the sands of time, the KD, the ability of these molecules to bind transmembrane TNF is quite a bit different, and is particularly different if you look at etanercept, that it requires a much higher concentration, okay, to bind transmembrane TNF. So these agents are much more specific for soluble TNF than for transmembrane TNF. That is the TNF that's on the surface of the monocyte or the macrophage or the T cell. Just to put it in comparison, methotrexate for dihydrofolate reductase has a KD of 500 picomolar, so it's quite a bit higher. Aspirin, does anyone know what the affinity constant of the KD for aspirin is? It's irreversible, so it's essentially infinity. Remember, it acetylates the enzyme and does not depart. So how do IMIDS inform us? Well, they inform us because in contrast to all the mouse data, where the mouse studies have predicted that IL-17 inhibitors would be great for everything from inflammatory arthritis to multiple sclerosis, when you take them into the human with biologics, the answers have been very clear. TNF and IL-6 have non-redundant pathways. That is, if you inhibit them, they improve the disease in our rheumatoid arthritis, but not IL-17 or not IL-17 so much. There might be a patient somewhere that responds to IL-17 inhibition, but that's the way it is. And in ankylosing spondylitis, TNF and IL-17 inhibitors are very effective, so implying that those two cytokines are very good, but anti-IL-6 therapy has not been shown to have any activity. So I'm going to start, in this model, I'm going to start with having you think about new actions, new activities, and new targets. So here's my first case. 59-year-old man is admitted for recurrent hematuria on awakening. He also feels very tired. His urine's only red in the morning. His hemoglobin is 6.5 milligrams per deciliter. His renal function is normal. Any ideas about the diagnosis? What? PNH, that's right. And what we're going to talk about PNH is a model for talking about complement. And remember, complement does many things, but one of the most important things it does is clear debris. As Lenny referred to in the first hour, it's also very important your innate immunity. It's also very important your adaptive immunity. And it's also very important to clear immune complexes, as I'll talk to you in a second. Remember, all of you were showered with immune complexes this morning when you flossed and brushed your teeth. So what happens all throughout our body, essentially all the time, is that C3 is being hydrolyzed and being generated to generate the C3 hydrolyzed factor B complex and be deposited on the cell surface. Any cell in your body, it's happening all the time. So we're always having C3b, factor B deposited on our complex. So we're always generating C3b convertase. But guess what? Nothing happens. The reason why nothing happens is that we have very good inhibitors of the C3b convertase activity. And there are things like CD55 and CD59. And what I want you to think about is in PNH, is there's a mutation, so you typically lose the tail that holds these molecules on the cell surface. So now what happens is the C3b factor B generated through the alternative pathway gets deposited on the cell surface of a neutrophil. Instead of CD59 and CD55 cleaving it, what happens is that this gets deposited, it generates C5, which then deposits C5b. Remember, C5 is also going to get clipped to C5a, and we'll return to that in a second. And you get a membrane attack complex, and you rupture the red blood cell. Now, this happens mostly at night because acidosis favors this. Respiratory acidosis favors this reaction. So this has been revolutionized by the treatment with anti-C5, or eculizumab. And eculizumab is a human antibody. It's very pricey, but it works incredibly well for the treatment of PNH. It also works incredibly well for atypical HUS, or hemolytic uremic syndrome. Has anybody used it for hemolytic uremic syndrome? A couple of people have. So remember, hemolytic uremic syndrome, the atypical form, not the one associated with Shiga toxin, is often associated with genetic mutations in complement regulatory proteins. So they get increased activation of C5, and you have to take care of that. So what happens in PNH is that you give an antibody to C5, and guess what? You block C5, you still have the C3 deposited on the erythrocyte, but you have no C5 leading to the membrane attack complex. So the red blood cell stays partially opsonized, but not completely. Now, why am I showing you a complement cascade? I'm showing you a complement cascade because I'm going to have you, hopefully, going to have you think about complement in a totally different way in about 5 slides. Remember, we generate complement. The complement cascade occurs either through the classical pathway shown on your far left-hand side, which is immunoglobulin dependent, and you get C1q, C1r, C1s, which cleaves C4, which cleaves C2, which cleaves C3. You can also activate it through the mannose binding lectin pathway, except where the C1, CQ, C1q, C1r, C1s is instead done by mannose binding lectins, so proteins that are part of the innate immunity, which are designed to bind to or recognize mannose sugars, which are primarily found on bacteria. And then finally, the last pathway is the alternative pathway that gets activated, can be activated when C3 is activated either by the mannose binding lectin or the classical pathway. And we call that the alternative pathway, and it leads to C5, cleavage of C5a. C5a binds to the C5a receptor, and that has powerful anaphylatoxic activity. So what you may or may not know is that when this pathway gets going through either of those mechanisms, and you generate C3b, the breakdown fragment of C3, is that the alternative pathway gets kicked in. And the alternative pathway is sort of like stomping your foot on the accelerator. And probably about 80% of your C3b that's subsequently generated in any immune response, even if it came originally from the classical pathway, is coming from the alternate pathway. Now, this is a very powerful system, and what the whole point of the system is to clear immune complexes and prevent inflammation. But counterintuitively, it's true But that's really the goal here. The goal is to generate as much C3b as you can at the down here and through either pathway, and generate all that C3b. And what do you want to do with that C3b? What you want to do with that C3b is decide whether you want to use it to clear immune complexes, or do you want to activate the C5a convertase activity, generate C5a, and bring in mass quantities of neutrophils, because C5a, remember, is an aflatoxin and has a powerful chemoattractant activity. So this morning, when you were flossing or using your Sonicare toothbrush, you generated bacteria, which are shown in green here, or teal covered bacteria, sort of like they're marlins, I guess. And what happens is they get bound, the immune complexes exist, those immune complexes are formed. The immune complexes are immediately recruit complement deposition onto the immune complexes. And those immune complexes are bound by, you guessed it, the red blood cell. The red blood cell has complement receptor 1 and binds those immune complex and acts like a freighter, acts like a big cargo ship carrying, what are those, the big rectangular boxes they call them? Yeah. Carrying those, and it's carrying them to a specific place. The place they're carrying them to is the liver. You're trying to keep those immune complexes from being deposited in the skin, the joint, the kidney. And this is what's really, and so the idea is to get those immune complexes out of the blood vessel as quickly as possible and get them cleared. And we are engineered, our livers are very, very good at doing this. Okay, so timing is everything. And what happens if your immune complexes get deposited in the vessel wall? Well, we usually call that vasculitis. But how does it get to be vasculitis? Well, what happens, they recruit complement, but before that complement can be bound, that C3b can be bound by the red blood cells, it generates C5a and also wants to generate some membrane attack complex. But I want you to focus on C5a, because C5a recruits neutrophils. Neutrophils have C5a receptors on their cell surface, and they are powerful. C5a is called an aflatoxin for a reason, in that it recruits neutrophils. It used to be that many patients undergoing dialysis used to have hypoxic events, and that was due to the dialysis membrane activated C5a, causing leukoagglutination in the lungs after they came back, the neutrophils came back into the body. So what we want to do is minimize the generation of C5a, or minimize its effects. So how might we do this? Well, there's a small molecule that's just been discussed and been in study for a couple of years that blocks the C5a receptor, and it's efficacious in ANCA-associated vasculitis. So this came out in, I think it was December. I don't know if it's in the nephrology literature. I don't know if it's been showing up elsewhere. But I want to remind you of what this trial was. There were 67 patients. They were all getting either rituximab or cyclophosphamide. It didn't really matter which one. They were randomized independent of those treatments to either placebo with 60 milligrams a day, avacopan or avacopan plus prednisone 20 milligrams a day. That was the C5a receptor inhibitor, or avacopan plus a placebo. So remember, this is kind of guts ball, right? I'm kind of impressed not using any prednisone in somebody with an acute ANCA-associated vasculitis. Pretty impressive. So what happened? Well, in their BVAS scale, the Birmingham Vasculitis Activity Scale, there was greater than a 50% reduction at week 12. That was their outcome. 70% achieved it with the standard of care, that is, placebo plus prednisone 60 milligrams a day. 86% with avacopan plus low-dose prednisone 20 milligrams a day. 81% with no prednisone. So one of the interesting things, and maybe we'll return to this in my second talk, is corticosteroids have been such a necessary poison part of our life. Maybe these are not going to be true going forward. The p-value for non-inferiority, remember they were going for non-inferiority here because superiority being required enormous numbers, was really quite striking. And there were no significant adverse events. Now, before I switch, I just want you to think about this. So what is this telling us about the pathobiology of ANCA-associated vasculitis, which I, for one, have found perfectly mysterious? There's an antibody that's strongly associated with it. There's no immune complex disease that we typically see on biopsy, but here we have a C5a receptor inhibitor blocking it. So I'm mystified. I share my mystification, my mystery with you, and there are probably ways we could talk about this, and there's complex diagrams and so forth, but I think this is going to remain to be sorted out. Okay. In my second case, this is actually this is a real case. This is a 26-year-old medical resident who, when he was at Dartmouth, he developed some rhinitis and mild asthma, and then he left Dartmouth and went to do his hematology-oncology fellowship at another hospital in another city. And while there, he lost his sense of smell, and everything seemed to get worse. In 2005, he had terrible sinusitis, terrible asthma. He had some nasal polyps with surgery, negative RAS, negative IgE. In 2006, he had night sweats, more symptoms. He was requiring 20 or 30 milligrams of prednisone every day just to get through the day, except when he went home to Greece. When he went home to Greece, played volleyball on the beach, he was perfect. He said, I felt great. I said, well, why didn't you stay at Greece? And no, I didn't say that. And but when he would come back, within a month or two, all of his symptoms would come back. So what's the diagnosis? Churg-Strauss. That's exactly what it is, and I just want you to know is that his FEV1 was 75% predicted, his ANCA was negative, there were no eosinophils, and he had a low IgG when he first came to see me, probably because of the fact that he'd been chronic steroids. So this is before the drug I'm going to talk about came up. So we gave him cyclophosphamide, 1 gram times monthly for 7 months. We gave him steroids. His life was ruined, by the way. He had an NIH R01 grant that he actually had to give back because he was so sick, which I was talking with Dr. Looney at break. You know, R01s are like buying Amazon stock in 1995, right? You know, anyhow, he was incredibly sick, and he got very modest benefit with rituximab and cyclophosphamide. And then he was working in a city that's near Dartmouth, and he heard about a clinical trial for asthma with mepolizumab, which is an anti-IL-5 antibody. And everything melted away. He was on background MMF and needed some prednisone, but it was much, much lower doses. And what happened was that he got his last dose of mepolizumab, and this is in 2008 or 2009, and the mepolizumab trial for asthma failed to hit its endpoint, and mepolizumab got shelved. The trial got shelved, the drug discovery ended, and he was out of luck. We put him on some mycophenolate. He had some chronic needs for steroids and inhalers. And then in 2016, he was able to get mepolizumab for his EGPA, and he's gone back into remission. So what happened here? Well, what happened here was a couple of things. One, some clinical trials. I want to point this out to you. Now, eosinophilic granulomatosis with polyangiitis is certainly controllable by steroids. And this clinical trial was designed to take patients that are on a stable glucocorticoid dose requiring prednisone and give them mepolizumab 300 milligrams IV monthly. And the remission rate, the criteria for remission was that you had 16 weeks, or I think was it 16 or 24 weeks, you had to have a BVAS of 0, and your prednisone dose had to be at 4 milligrams a day or less, and there was a fixed taper. And here's the data that I want you to look at, and this is from the New England Journal paper, is that the group that was on methotrexate at 44 weeks, but by 24 weeks, 44% had met the target value. They were on a prednisone dose less than 4 milligrams or less, and they had a BVAS activity scale of 0. Now, please note that the placebo group was 7%. So what this is in effect telling you that Churg-Strauss, eosinophilic granulomatosis with polyangiitis, is an eosinophil-dependent disease. So this is how IMIDS inform our therapy and our understanding. Now, what about the fact that it's making their asthma better? Why did imepolizumab fail the clinical trial for asthma? Well, the problem with that trial was that it had very broad criteria for asthma. If you define your asthma population by having eosinophils, either on your BAL or in your periphery, a requirement for admission in the previous 6 months for your asthma. So picking a refractory, severe group. What happened is that when that group came in and they looked at asthma exacerbations, and you can see the cumulative number of asthma exacerbations in the placebo arm is about 200. If you look at the group that's getting mepolizumab 75 milligrams intravenously every 2 weeks, or 100 milligrams once a month, you can see a clear difference. So it's all about defining your patient population. So IMIDS, and this is one of the mysteries and challenges, IMIDS may have activity, but they have to have activity in you have to look at the right patient population. So we talk about eosinophilic granulomatosis with polyangiitis. We talk about genetic determinants. There's some associations with DR haplotypes, particularly in Japan. There's some other, there's this clear requirement for environment. I told you about this. He would go home to Greece and he would be fine, but when we returned to the Northeast, he was much not as well. Now he's living in San Diego, so I think I'm not sure his remission is due to the drug. No, that's a joke. But he's much more Mediterranean in his overall lifestyle. There's all these different possibilities, but I also want to alert you is that chronic obstructive pulmonary disease with the eosinophils is responsive to mepolizumab. So who would have thought chronic obstructive pulmonary disease is going to be responsive to anti-IL-5 inhibition? But the answer is, it is if you look at the right patient population. So everything's about patient population and controlling it well. Okay, so I'm going to wrap up. I hope I stayed on time, kept us on time. The protein-based and small molecule approaches to complement are likely to shape any of the treatment to many, many diseases. So I can't, a C5a inhibitor that you give my mouth doesn't have a lot of toxicity. You can bet that people are going to look at it in other disease states. And we're going to have to expand the way we think about complement, right? It's not just about having a low C4 and a low C3, because that doesn't exist in ANCA-associated vasculitis, or typically doesn't. Eosinophil-based diseases with mepolizumab has refined and established the need for very carefully defined patient populations, but also you as treating doctors have to have those refined patient populations in your own, when you reach for drug A versus drug B versus drug C. You can't reflexively just go here or go right there, or I don't think you can. We don't have enough data to really derive that. And finally, these agents can be life-changing, and there was nothing greater than having my patient, who I kind of lost to follow-up in 2016 when he moved to California, bumping into him in San Diego at the ACR meeting last November. Okay, so questions to test your attention and knowledge of movies. Mepolizumab is an effective treatment for certain types of which diseases? A, asthma, B, COPD, C, eosinophilic granulomatosis, polyangiitis, or D, all of the above? D, okay, right, correct answer. Which of the following statements is true about ANCA-associated vasculitis? Hypocomplementemia is common. Complement inhibition is an effective treatment for AAV. PR3 autoantibodies are associated with low C3 and C4. And renal complement deposition is a signature finding of ANCA-associated vasculitis. B, correct. Excellent. You're good at batting 1,000. Anti-C5a therapy has been shown to be effective in AAV and paroxysmal nocturnal hemoglobinuria, AAV and atypical HUS, HUS and myasthenia gravis, HUS, myasthenia gravis, and PNH. I didn't mention this. It's D. It actually works. It also works in myasthenia gravis. So So this, we're blocking a neuromuscular junction, and who would have thought, we think of an antibody just binding and doing its business, who would have thought complement's involved? But if you block C5, you get activity. How you get activity is not quite clear. Okay, thank you very much.